finishing discussion about the diseases of the pulp, we will be moving on to diseases of the periradicular tissues. First, we will discuss the same, and then at the end, we will very briefly cover the rationale of endodontics as to how the treatment helps in removing the disease that is occurring at the periradicular space. Pulpal diseases is only one of the several possible causes of disease of the periradicular tissues. Because of the interrelationship between the pulp and the periradicular tissues, pulpal inflammation causes inflammatory changes in the PDL even before the pulp becomes completely necrotic. Diseases are of two broad classification. One are the acute type and the other is the chronic type. First, we will elaborate the acute type. In number 1, we cover the acute apical periodontitis. It is a painful inflammation of the periodontium. In vital tooth, the causes might be due to abnormal occlusal contacts or due to trauma or from food impaction. Whereas in a non-vital tooth, acute apical periodontitis is present. Reason probably would be a sequel of a pulpal disease due to root canal over-instrumentation or perforation or over-obturation. Symptoms are pain or tenderness which may be mild or even severe. Tooth may feel extruded or pain on closure or chewing. Diagnosis is pain on percussion, which is a classical feature of acute apical periodontitis. X-ray will show thickened PDL or small area of rarefaction in case of non-vital tooth. Treatment is to determine the cause and relieve the symptoms. That is, in case of a vital tooth, if occlusal adherences are there, then selective grinding, and in case of a non-vital tooth, find out the cause and treat accordingly. Prognosis is generally favorable. Moving on to acute alveolar abscess. Here, after the infection has occurred, it involves the adjacent bone as well. It is a localized collection of pus in the alveolar bone at the root apex of a tooth following death of the pulp, with extension of the infection through the apical foramen into the periradicular tissue. Causes may be bacterial most likely, or trauma or chemical sometimes. Symptoms are tenderness, and we can find a draining abscess if we do the examination properly in most cases. Diagnosis: a radiograph may help. EPT and thermal test will give no response because inside the pulp is entirely necrotic. Treatment: first we have to establish drainage and control of the systemic reaction that is occurring. Since the pulp is necrotic, actually anesthesia is not needed, but probably this is the tooth that is the causative one. So some kind of a conduction anesthesia, that is from far we can inject a little bit so that while drilling, the vibration and all that does not feel a lot of discomfort for the patient. Here, test cavity will have a twofold benefit. One will be diagnostic, as well as it will usefully help in establishing the drainage as well. Also, if there is a buccal, we see a pustule occur, or probably in the palatal region. So there also, at the most dependent site, an incision and drainage should be established for better amount of the pus to get drained. And antibiotics is must to be prescribed along with analgesics for this case. Acute exacerbation of chronic periodontitis. Synonymous word is phoenix abscess, most commonly associated with the initiation of root canal in an otherwise asymptomatic tooth. X-ray shows a well-defined periradicular lesion. Patient gives a history of trauma that led to discoloration of the tooth. In vitality test, known response will be assessed, reason being pulp is necrotic. Sometimes false positive may occur due to multi-rooted tooth or fluid presence in the root canal. Treatment is similar to acute alveolar abscess. Moving on to the chronic list of diseases. First is chronic apical periodontitis. It is a symptomless sequelae of the acute counterpart and is characterized radiographically by periapical radiolucent changes. Synonymously also called as periapical granuloma. The cause can be death of the pulp from a continuous but mild infection. Usually it is asymptomatic, and diagnosis generally takes place while doing a routine full mouth examination. Area of rarefaction is well defined with lack of continuity of the lamina dura. RCT usually suffices. Once the cause of inflammation is removed, resorption of the granulomatous tissue and repair with trabeculated bone takes place. Chronic alveolar abscess, a long-standing low-grade infection of the periradicular alveolar bone. Here, draining sinus is present. Cause, it's a natural sequelae to death of pulp. Symptom, generally asymptomatic. Intraoral or extraoral sinus tract can be seen. Sinus tract opening prevents the exacerbation or swelling by providing a continual drainage from the periradicular lesion, so as there is no excessive swelling that is taking place, which can cause a lot of pain. So that is the reason for this particular thing. Diagnosis is generally while routine examination. The patient does not actually come with any intense pain. Only thing they can say that some amount of, they are getting some pus kind of a feeling in the mouth, the taste is odd. Then we might check and see there is a sinus tract opening. Also, if it's an extraoral sinus tract, then it's a fairly direct diagnosis. Diagnosis X-ray has to be done after placing a medium thick GP, probably a 30 number GP point. So we place it inside, and the GP, even though it might go inside from a particular position, it might take another route and lead to a different tooth, whereas here another tooth was here. So judging by the location of the sinus, we should not directly go for a diagnosis that this is the causative tooth. The GP tracing that touches a particular tooth, so that is the causative tooth. A very important point to note here. Generally, depending on proximity of the root tip towards the labial or palatal bone, the sinus opening is through that path of the least resistance. When asked, patient may remember that there was a sudden sharp pain which subsided and has not recurred, or maybe a history of trauma. Treatment, RCT is helpful, but with inter-appointment dressing until the symptoms have subsided, and only then we have to go for the obturation. Next is the cystic apical periodontitis, also called as the radicular cyst. It is a slow growing epithelial sac at the apex of a tooth that lines a pathologic cavity in the alveolar bone. Causes: pulpal death followed by stimulation of the epithelial cell rest of Malassez, which are normally present in the periodontal ligament. Symptoms generally asymptomatic. The pressure of the cyst may be sufficient for the tooth to become slightly mobile. If left untreated, the cyst may expand at the cost of the maxilla or the mandible. Diagnosis: negative response to EPT. Radiograph shows area of rarefaction. Treatment: surgical enucleation of the radicular cyst is not always necessary in every case. Resolution of these areas of rarefaction occurs in up to 80 to 90% of the cases only with root canal treatment. Surgical intervention is indicated only if the lesion fails to resolve or if the symptoms develop. Persistent apical periodontitis. It is a post-treatment apical periodontitis in an endodontically treated tooth. Certain factors that might contribute to the causation are anatomical complexity of the pulp space, perioapical biofilm, foreign body reaction to gutta percha, or medically compromised patients. Next is the condensing osteitis. It is a mild irritation from pulpal disease, stimulates osteoblastic activity in the alveolar bone. It is generally asymptomatic, and only in radiograph there will be the appearance, and treatment is needed if irreversible pulpitis is diagnosed, and in such case endo has to be initiated. Coming to external root resorption. It is a lytic process occurring in the cementum alone, or sometimes cementum and dentine of a tooth. Causes generally unknown, but suspected causes are some time back a trauma was there, or some excessive force due to fixed orthodontic treatments, if there is a history of a replantation surgery that has taken place, or any tumor or systemic disease. In case of replacement resorption, tooth is rendered immobile. It is in infraocclusion and on percussion there is a high metallic sensation that is there. Diagnosis can be in the diagnosis. X-ray will show concave or ragged areas of the root surface or blunting of the apex. So if this is the tooth, we can see like this some ragged portion where resorption has taken place, or probably the apex, instead of being pointed, it may be blunt in nature. That will show this area has resorption has taken place. In case of external cervical root resorption, surgical exposure of the defect and repair should be done before pulp is involved. Prognosis is guarded depending on how much of the tooth structure has already been destroyed. Here I want to personally emphasis on a very important part, that is the importance of patient education and educating them more regarding the importance of routine examination. We saw in the last part of the video that how much of all the chronic diseases of the periradicular tissues are present, which silently keeps destroying the tissues and the tooth, but the patient, since there is no active pain, active swelling, the patient does not come to see the dentist, and in turn the tooth, when it probably is in a way of kind of a lot of destruction and in a situation where probably further the tooth cannot be saved at all, only then the patient comes. So we should always educate them for a routine examination at least once in a year or 2 times in a year, depending on the oral situation of that particular patient. Moving on to the second part of the video, here we will briefly discuss about the rationale of endodontics. Irreversible inflammatory changes caused by severe injury can lead to necrosis of the pulp and subsequent pathologic changes in the periradicular tissues. Since pulp is encased in hard tissue with limited portals of entry, it is an organ of terminal and limited circulation with limited space to expand when an inflammatory reaction is taking place. What is inflammation? It is a local physiologic reaction of the body to any noxious stimuli or irritant. The irritant produces a sequel of physiologic or morphologic reaction. The objective of inflammation is to remove or destroy the irritant and to repair the damage of the tissue. But we have to keep in mind that repair will depend on the severity of the injury and the host resistance. The injurious agent may cause reversible or irreversible changes to the tissues. Irreversible damage leads to tissue necrosis, whereas reversible damage will lead to repair. This reparative tissue, which contains new blood vessels, fibroblasts, collagen fibers and inflammatory cells, is called granulation tissue. The inflammatory process resolves when repair has been completed. The vascular changes during inflammation are vasodilation and increased permeability of the capillary. Revising the very old 5 cardinal signs of inflammation, we have rubor, that is redness of the tissue; calor, where due to vasodilation there is increased heat; dolor, pain from the action of cytotoxic agents released from the humoral, cellular and microbial element on the nerve endings; tumor, that is swelling; functionalism, in some cases due to all these disturbances there is some loss of function. The cells that are majorly present during this action are the pigments, the macrophages, lymphocytes, eosinophils, basophils and mast cells. Periradicular manifestations. If the inflammatory response overwhelms the pulp, partial or total necrosis occurs and the root canal serves as a pathway to the periradicular area for the noxious products. These products produce bone resorption and granulation tissue in places of normal periradicular tissue. This is a diagram to remember while we are discussing this topic. So here inside the bone, when the pulp has been completely necrotic or infected, this serves as a zone of necrosis. Right out of it is the zone of contamination. So in the zone of infection, what happens is mostly the pigmentals are found, and in fish study it was seen that infection was present in the center of the lesion and that the microorganisms were primarily found in that particular area. Zone of contamination characterized by round cell infiltration. Cellular destruction occurred even from the bacterial toxins that were discharged from the central zone into this other zone. Zone of irritation, the third one. Here macrophages and osteoclasts were mostly found. Collagen frameworks were digested by the phagocytic cells, where that is the macrophages, while the osteoclasts attacked the bone tissue. And lastly was the zone of stimulation, the most periphery zone. Here what happened is mostly fibroblasts and osteoblasts were seen, and the concentration of the toxins were kept on decreasing, so that mild toxin acted as a tissue stimulant, and this zone acted as both a wall of defense where it is not allowing any intermixing of the healthy and the diseased tissue, as well as a scaffold for irregular new tissue formation to take place. So all in all, when the root canal has been completely treated, these necrotic pulps have been taken out, what happens is the reservoir of bacteria and the noxious products get eliminated, and then what happens is slowly after the obturation has happened, in this area new bones started getting developed and repair takes place. So after all the discussions, a few cases where even after all treatment plans and all the protocols also, we have to take a decision of not trying to save the tooth. Some of the cases are symptomatic teeth in which the canals are non-negotiable and have been calcified, or probably some iatrogenic errors such as ledge formation or canal transportation, something like that, or perforation. Other option would be an endodontically treated tooth which is exhibiting failure multiple times even after surgical or non-surgical treatment. Third one will be where there is an irreparable fracture, probably a single rooted where a vertical fracture is there, or somewhere is an irreparable fracture. And fourth option would be where extensive periodontal disease with loss of bone support is there, causing irreversible mobility of tooth. So even after all treatment, there are few cases where we should not still try to save the tooth. In that case, we have to take the other alternatives of rehabilitating the patient after a less painful extraction. So that's all for today. We will see you again in the next video. Hope you have enjoyed learning with us. Thank you.